Welcome back, everyone, from the lunch break. I hope you had a great opportunity to grab some nourishment and hopefully get a little bit of movement in as well. We are back with the wonderful Dr. Mary Jane Esplen, who is speaking to us today about coping skills for the colorectal cancer journey. So Dr. Esplen is a very valued member of CRAN's Medical and Scientific Advisory Board, and she also helps to lead our patient support program development. Dr. Esplen is a professor and the former vice chair of the Department of Psychiatry at the University of Toronto, and also worked as a clinician scientist at University Health Network as well as Mount Sinai. She founded the D'Souza Institute and has held Career Scientist Awards for psychosocial oncology research, completing studies of psychotherapeutic treatments to support adjustment to being diagnosed with cancer or receiving genetic risk information. Other areas of research include studies addressing body image among cancer survivors, as well as the management of grief and loss. Dr. Esplen gives numerous workshops and keynotes and has received several awards, including the Lifetime Achievement Award from CAPO, the Canadian Association of Psychosocial Oncology, and the Bernard Fox Memorial Award from the International Psycho-Oncology Society. So Dr. Esplen, it is my great pleasure to hand it over to you for your presentation today.
Thank you very much, Cassandra, and to Crane and everybody. You know how I feel about what you do, and thank you, Phil, again. I was just saying how everything gets fancier in her systems over there. But I think a lot about what you do to the coaches. It's so important. And I have at many conferences said that even though for sure we have some excellent psycho-oncology services, not everybody has easily access. We don't really have enough. And depending on where you live, and even then, you may be limited in how many sessions. So, really, we do rely on peer and this type of support as part of our continuum of care. I really believe that you're part of the team. So, it's really important what you do. And also, I know that many of your peers, meaning you've been through the cancer experience in some capacity yourselves, you can provide a kind of support that those of us who haven't experienced the illness personally may not be able to provide. So it's also a very unique source of support. So what I'm going to try to do is, and I'm sorry if I repeat from other years, but I will walk through some of the major experiences and what we know a little bit from the research. And then the next part will focus on kind of the coping area and some resources. And then we'll have some time, hopefully, we'll have time for classes, for questions. I have to remember to do that and leave some time for that. So I'm going to share, right, I think, yeah. Let me know when you can see it. You can see it. Okay. Just trying to. There. So there are many types of stressors. So it's very normal to have stress, and it's part of the whole experience. And that's why psychosocial oncology and psychosocial care now is integral to overall cancer care. And I know you're hearing from a lot of other health professionals over this week, but the psychological, and people worked very hard in that before my time, really. And Canadian Association of Psycho-Oncology worked hard in this to really help the health services policymakers understand that the psychological components are a real part of this and also need to be addressed. And people have a right to this type of care, as well as we want to normalize that. One of the roles that you have is to really validate and normalize. And so these are some of the stressors and including financial, emotional, mental stress, physical stress. I always say to our health professionals, every single thing we do, all of the treatments leave some residual impact. So surgery, chemotherapy, immunotherapy, radiotherapy, scar, everything, we leave scars in everything we do. We leave impacts that are sometimes psychosocial, sometimes it's fatigue, sometimes it's other types of responses, but they're part of the having to cope with this. Our survival is doing better, and just want to be able to see this, yeah. Our survival is better. And that means that people live longer, often with cancer. So again, those residual impacts can be very challenging and part of getting back on track and going forward in life. So, but survivorship's been defined as the time since really diagnosis right to the end of lifetime of care. Now, this is from common needs, just to give you a picture so that you understand what actually could normal look like. You know, there's always ranges, but these are some proportions of people that are really talking about, these are all people that have had, this is a Canadian study, people that have had cancer. And, the proportion of people that still have some of these really unmet needs. Fatigue is common. It has impacts on our sexual functioning, change in concentration. You've heard about chemo, brain fog, nervous system issues, challenges around stress, anxiety, and changes in body image. And the good news is everybody does adjust in their own way. Majority of people do adjust over time and explain and feel and report that their emotional and quality of life is good or very good. And 61% in this Canadian study report that it's easy to cope with the challenges mostly day to day, and 44% found it easy to share their worries or concerns with others. But not everybody does. And sometimes you're in a position where you're going to be trying to explore and know more about what it is they're experiencing. And one of the things I always try to teach and remind people, even though, I'm showing you a few studies and rates and common symptoms. What you want to do when you're talking to your one-to-one recipients of your care is try to understand what are their specific emotional concerns. You want to get to the personal and the most concrete you can, even though, the actual concerns or reactions overlap and are common. You want to understand what is their personal experience, what is their major concern. I'm going to give you some tools around that later. But these are some of the common emotional concerns. So loss of interest and depression is quite common. Rates vary from 25 up to 75%, depending on maybe when you're measuring depression, the type of scale you're using. So very common. Sadness is a very common response, and so is anxiety, and so is fear of recurrence, actually very common. But these are some of the rates in a national survey on needs in the survivorship period. Fatigue is also one of the most common concerns I hear about, and I'm sure you're going to hear about. But there are other types of concerns too. So depending on what the treatment is and the type of cancer, and even in prophylactic removal of ovaries and breasts, you can have hormonal changes. And, if you have your ovaries removed, you're going to go into early menopause virtually overnight. And there's changes in fertility. So these are things to think about depending on the age and the recipient of your care. And, chemo brain fog, I hear a lot about, and we don't always talk about this, and you're going to hear this in the next section, which is great, the impact on sexual functioning, especially with your younger patients, but also your older patients. So they can have negative effects. So worry and isolation and not sure how to help. Fear for offspring. People often are thinking about their family, certainly in the genetic ones, the inheritable types of cancer that you're also hearing about at this summit. There also can be positive effects, though. For example, sometimes people report that their couplehood, their marital adjustment improved, like their feelings about their relationships improved. Um, so bringing a couple closer together is something we hear about. But it is a family affair. I always remind people of this. In fact, I've seen studies where sometimes the spouse can have higher levels of distress. And when I say distress, we're often measuring symptoms such as depression or anxiety when we think about stress and distress, or the fear of recurrence, or the perception of being at risk for cancer. These are areas of unmet needs. So even though we have psychosocial oncology programs now fairly well established, again, in smaller centers, rural communities, and not everybody has easy access. And sometimes these types of services get reduced or because of financial resources are even eliminated, unfortunately. These are the concerns of unmet needs. and often very well into the survivorship period. So emotional concerns by high level, physical concerns leave residual impacts like neuropathy in fingers, the chemo, brain fog, feelings of fatigue, practical concerns, going back to work. I'm going to show you the return to work website can be very helpful for some tools and to guide your patients to. And 84% of our patients in Canada, is this the Canadian one? Yes, have reported that they've had at least one need that's not really met by our system. And these things depend on the age, the financial status, socioeconomic status, maybe where they live, type of treatment, and the type of cancer that they've had. One of the things I always remind people, and this is important to keep in the back of your mind, the period of transition is often a source of distress, and we don't always think about it that way. And that includes life transitions, but a very common one, and maybe you've experienced this yourselves, is when you're in that active treatment phase, people often feel that they're well taken care of. They feel they're being watched and monitored. You're very busy with all that's going on, your treatments. And then all of a sudden you're told, well, you don't have to come back for 3 months or 6 months or whatever the follow-up period may be. And that can actually leave people surprisingly, they're very surprised by this, that they feel more sadness or more anxiety. And they have this decreased contact with their healthcare providers. And it really, it actually surprises people. They didn't expect to feel like this, and the family didn't expect their loved one to feel like this either. And so this can be kind of ambushing, and they can feel a sense of being abandoned, unprepared for this. So we're always reminding our nurses to let patients know that this is very common to be expected part of the change as they go through that transition. This is just some experiences that are common. Friend came over to see how this person's been doing. She said that she's had crying spells due to her bodily changes and changes to how she views herself. Here's another quote from patient. I'm here to find a sense of control. I want to know how to cope and what will give me control. I see this a lot with people that are told that they're at very high risk for cancer and they carry a cancer gene mutation. And they've had a lot of family history experiences in their family. And people also worry about the cancer returning. The fear of recurrence is very, very common. And this is something we see too. There's an internal sense of suffering. No one really understands how I can feel isolated, even when the prognosis is good, even when they appear to look good, even when their family tell them they look good, and people thinking they should get back to work and so forth. But people can feel pretty alone and isolated. The other thing that I think drives some of the psychological impacts is the whole area of self-concept. And what I mean by that is we all have one, a view of how we see ourselves. And we can have a view of ourselves in the past, a view of ourselves currently, but we also carry images and ideas around how we may see ourselves in the future, including how we age or how we may see ourselves down the line. And this whole area involves one's self-esteem, your confidence, could involve confidence around personal health and future sense of health. And I think the cancer diagnosis really can play a role in the altered sense of who people see themselves now, who they thought they would be, who they think they may become. And this is an area that I think loved ones can find difficulty in really understanding. You're the same person. They think they're the same person, but people can feel very different in going back to the kind of roles they had, the roles as a parent, or maybe their work-related roles. They may have a shift in what's valuable and meaningful to them now, where their priorities are. It doesn't always happen, but certainly the treatment impacts can have a change in how somebody might view themselves. This is a photo of a young man with cancer, afraid of getting sexually intimate with a new partner, fearing rejection, very common concern for the sexual types of the sexual organ types of cancers that you're going to hear about in the next session. And I think often these feelings are dealt with alone. They don't know where to go to get help. They're not sure they should burden the healthcare team, including the doctors. If it's areas of body image concern or sexual functioning, they often feel embarrassed, shame, or maybe afraid to bring it up because they do feel very glad they're alive. Our healthcare is focused on sort of the whole area of survival. It's acute care and survival. But we leave patients with these residual changes and impacts, and they don't want to be perceived as vain or shallow, but they're dealing alone often with them, and they're sometimes afraid to bring them these issues up to their physician, the physicians looking after them or the nurses, or even in follow-up. It doesn't make sense to them because they want to show gratitude that they are doing well or alive, but they're afraid to bring up some of these more personal areas. So what can they do in moving forward? So I think about it in Stanton in a paper had written about emotional functioning. It's really about, well, how are all of these changes or impacts affecting their emotionality, physical functioning, effects on relationships, and their whole quality of life perspective. It's very helpful, and this is why peers do so well with coaching. It's very reassuring for them to know that this is normal. They're not the only one that feels these types of things, but not overly normalized where it might shut them down from opening up to you, on the other hand. But it does give them, some credibility that this is only natural part of going through cancer. This is a model showing areas of resilience. So these are clues around things that you want to support, developmental and coping tasks that will help them build resilience and maintain or improve their quality of life and lead to effective coping strategies. So purposefulness, um, you know, their sense of confidence, their sense of social support. We know that, and so check on that. Social support or the wellness types. I like Wellspring a lot, the group programs, anything that can decrease their isolation, which is part of what you do. It can, or their own area of social relationships or communicating with loved ones. Social support's a buffer around stress. We know that. We know that from multiple studies. It can help people cope. It helps decrease isolation. Sharing coping strategies and support groups can be very effective, but it just helps build some resilience and buffer against stress. Confidence. So having and anything you can do to encourage feelings of feeling competent and effective with their coping and managing the stress that they're dealing with can really help them with their positive outlook, as well as looking ahead, and build their confidence. And remind them when they're doing well and what they're doing well. You want to identify their areas of strengths. We'll come back to that later. And then purposefulness. This is one of the areas of cancer that's very interesting. Not everybody sees silver linings. That's not always a good term to use, but people often do have a sense of meaning after learning so much about themselves as they've gone through the cancer experience, learned about things about themselves they didn't know they could do, learned about their own source of strength, or were surprised about other areas of life, people in their lives, or areas where they didn't do well. But it can give people a sense or a renewed sense of their values, their goals, meaning making, anything around. And that's why you see sometimes people very involved with art later, maybe they leave a job and make a change that's really valuable and important to them, or not delay something, or the value of family and loved ones. These are things that become very salient during anything like the cancer experience, which is really a lot of losses, an extreme experience of something that's come along in their life and made a change. And when people experiences any types of traumas or something quite extreme that has impacts, it really results in them looking back in their life, but also looking ahead. It discombobulates people for a while. I often use that metaphor of the escalators that are horizontal. It's one of the metaphors I like to use because people are going along in life and then this happens. And they can be discombobulated and have a very jarring experience of the impact. But the escalator keeps going. So trying to help them, keep going, continue on that life journey and whatever's lying ahead is part of the task that you're going to be helping them with. So strengthening resilience. So helping people psychologically prepare. It's really good to know what to expect. This is something we tell nurses all the time. Like if you're going for surgery or you're having a colostomy or you're going to have to undergo a certain kind of cancer treatment, understanding what's going to happen to them, the types of side effects they'll experience or may not experience, like just knowing what to expect, how long it's going to be, what are the side effects, symptoms, what does it involve. That goes a long way to help people prepare psychologically and in their follow-up coping. So this is something you will do, and I know a lot of you do share through your own experience the common reactions, but also might be what might happen in a later stage when they're going through something new or even a clinical trial. Emotional insights, life balance, like making sure that they're, as they get back to work, taking time for themselves, getting back on track, like just examining and asking them about life balance. Spirituality is very important for coping. It doesn't mean always having a specific religion, but inquiring about and helping them to talk about their life meaning, areas of spirituality. This is why areas like meditation can be very helpful. Just personal reflecting. And this again, anything that helps people, on that escalator that goes along, that journey that keeps going on. I'm not sure if you like the word journey, some people don't, but the fact that you're continuing, any strategy that have a sense, help people know that they're continuing on, even though they may have lost some function and lost some aspects of themselves. There may be things that changed in a new way. They may have a new emerging sense of themselves going forward. So, some questions around some of that existential meaning making area could be trying to explore, and the cancer experience itself often prompts us, trying to find more meaning in life or the wisdom that they may have gained around themselves or other parts of life going through something so difficult as cancer, trying to see the big picture and really getting them to talk about it and you reflecting yourselves around the special moments that often you learn and experience when you're going through such an experience. People often talk about humility, being humble. I often ask people when I'm working with individuals in my practice or the groups that I've done, there's often a lot of talk about loss, and it's very important that people can talk about that and help process that. And I often ask, what did the cancer also bring into their life, if anything? Like, what have they noticed? New things they may have learned about themselves, new information, new awareness. What did it not take away? Anything you can do to foster human connection. Now, what I want to do now is shift. You've probably heard me talk about this before. It's a model that's used, a set of questions in the area of primary care. It's a model that came out of the UK. And we used it a lot when we were teaching nurses who work in cancer care or in the community who don't have a lot of time, how to get to that personal and concrete and prioritize where you can try to help someone. And it's published, but it's the BATHE, technique, and what those letters stand for, that an acronym. So you want to get some information on background of your client. Affect refers to emotionality, the emotions involved, the emotional concern. I'm going to come back to that. Trouble, T stands for trouble. What is troubling them? What is their primary concern? The H is how are they handling it? And E stands for empathy. The R and S were added later to the model to talk about screening and follow-up and referral. And you'll have cases, I think, where you will need to make referrals or encourage them to go to their team and ask for a referral for psychosocial care. So background, what you want to do here, and remember getting to the personal and the concrete, and even thinking about yourselves when you've been through this, what were the concerns you had? What were your primary symptoms? What did you have to grapple with? What was happening in your life at the time? So you want to get that understanding of the situation as best you can. And these questions are designed to get the context because even though two people can have breast cancer, how they experience it and their backgrounds and contexts will be very unique to them. So you want to get to that personal area. Emotions can be thought about in two ways. So that feeling state, you're checking on their emotional state. And this is really about the ways in which whatever the issue is, the cancer, the treatments, or the concern, how is it affecting their life? And these sets of questions allow the person and family member to report and label. So you're validating, you get a sense of what the exact emotion is. It may be distress, but you want to know, is it sadness or is it more stress and anxiety? Is it more like grief? Is it fear recurrence, which is a very specific type of distress, so that you can help them label it and understand what they're feeling, and you understand that. And here's some examples of questions. So they're just examples, tools you can use. So once you elicit that they're sad or fatigued or anxious, um, ask more about how they're feeling about it. What are they experiencing exactly? How is it affecting them? This is where you get into functionality more. Like, how is it affecting their day-to-day life? And you can ask it that way. How is it impacting them? Or how does it affect what they need to do each day in their chores or their roles or whatever it is they're working in? Or their caregiving or their mothering or being a parent, whatever it is they're trying to get done each day. And how is this affecting how they function in getting through the day? How long has it been going on? These are just some examples of question to get more about that personal and concrete in the emotional state. For the T, thinking about how is the issue troubling, you want to understand to what extent. You want to learn more again about the context, the personal aspect of this, so that you can cultivate and think about the right strategy for them. So, it might be a symptom, might be a situation. Uh, Sometimes these are the most important questions to get at the context and to get around, get more information about how are they interpreting in this, or what is the meaning of the situation. Here are some examples of questions that you could ask. What about that troubles you most? What about this situation troubles you most? What about the anxiety? Say they elicit a specific feeling or fear recurrence. What is that, that's troubling you? When you think about fear recurrence, say that's what they talk about to you. Tell me more about that. Like, what goes through your mind when you think about a recurrence, to find out what, and you may get something very personal back, like, well, I'm not sure I'll see my kid graduate, child from university, or I want to be here for my partner, or I'm not sure I'll be able to have a career, or will I get to retirement? Like, you're getting a little bit more personal and concrete by asking about that. What's troubling them most and how is it troubling them? And then the handling, you want to see their strengths and you want to see how they're doing with the issue and the stressor. So, how is that person that you're working with and the family maybe also handling the situation? And it reveals, you want to find out two things. You want to find out the resources and you want to find out where they're not doing as well, where they're having more trouble and need assistance. So, they give an idea of the person's functioning from the issue, and it starts to provide more direct areas for how you're going to help and assist. Possible questions again. How are you handling that? Just ask them. What have you tried and how is that working? What or who has been the most supportive right now in your trying to kind of grapple with and deal and handle the situation? How do you think you're actually handling it? How do you think it's going? This is an interesting question I put in too, because it can be helpful. Like, what is the best advice you've ever been given? You could also ask, what has not been good advice you've been given? This may lead to examples where, you've probably heard this a lot, and maybe you've even heard it in your own life or said it, but sometimes people say, just stay positive. And people may say, you got to have a positive attitude or, things won't go well. And positive coping is very helpful, but it can't, if it's the only way, that is very isolating to people often, because it can shut them down or close them down so they don't feel comfortable letting you know what's really disturbing them or worrying them. And that isn't great advice always, because it can make people feel even more alone, that they're really not people, they can't always maintain a positive attitude. Some people can't, it's so stressful and disturbing to have cancer, it's not a positive experience, and they can't, maintain that. And they may feel they're letting down a loved one or someone, or even a health professional, if a health professional gives that information, that they should try to remain positive. Empathy, you probably wouldn't be doing this work if you're not an empathic person, but it's the appreciation, acceptance of someone else's emotional state. And it really helps normalize, legitimize the experience, or their families. It helps recognizing the suffering involved in having cancer and specific points of suffering and help them feel more confident and connected to you and connected to the healthcare team and that they're heard. And it really allows you, again, to move forward with how you might direct them or assist them. So again, here's some examples, but you want to be open to all the range of emotions, not just the positive ones. You want to be able to help them open up. So you want to show your empathy. And these are examples. I can see that you are such and such, that you're feeling this or dealing or grappling with X. I can understand why you feel that way. That's giving that normalization and legitimizing that this would be a response that makes sense with something. I'm here to help. I want to try to help. Let's see what we can do here together. That's a partnership kind of model. And then, reinforcing their strengths and where they're actually doing well. That's really helpful feedback for them. And you can convey empathy both verbally and non-verbally. It's important because it's the human part of the cancer care that's really important with something that involves so much suffering and loss. It normalizes the experience. It reduces that sense of stigma and isolation. And think about the area of sexual health where people it might be really hard. They're not necessarily going to bring this up. And we were finding that a lot of health providers aren't even checking on this area. They don't have a lot of time. They're sometimes afraid of bringing it up. They don't even know how to maybe deal with it or guide them. So they don't bring it up. But that just makes people feel more stigmatized or more isolated. And that's going to increase distress, which you don't want to do. So you want to increase the coping and decrease the distress. Now, in terms of putting that framework together, just to remind you, and it's a good little, we used to give the nurses that we were educating at the D'Souza Institute courses a little card background with bathe on it, but it's the background, the emotionality, the trouble, the handling, and the empathy. Just remember the name. Now, our response and referral. So there will be times where it goes beyond what you're going to do in your coaching. We can talk about that more. It'd be good to have a network to refer to. And these are the types of things, if the distress is at a moderate level and seems to be increasing no matter what you're trying to do to assist them, if it's really complex cases and multifocal, a lot of different concerns, a lot of different stressors, if it's concerning to you, like you'll have your own gut feelings about this, trust that intuition, or associated with other risk factors, like a background of trauma, mental health background. We know that people that have had experiences of specific traumas, significant traumas, or even asking them, have you ever seen a counselor before? If you know they've had a depression before or bipolar disorder, any disorder, going through something else in their life, those are risk factors. It doesn't mean for sure they'll have more distress, but they're flags, and it might mean more assessment because we know that they can have more vulnerability factors in coping. And if the person identifies, like if you ask if more assistance would be helpful and they say yes, then a referral for sure is in order. Um, and how you can help make sure they go. Keep in mind, a lot of our patients in cancer care, they've never seen somebody in psychosocial or psychological help, never seen a psychiatrist, psychologist. And so you want to really make sure, because sometimes people make referrals or recommendations, they don't even go and follow up. So remind them it's part of cancer care. It's just that's why we have psychosocial oncology programs. All cancer centers are supposed to have someone to refer to now, or psychosocial oncology services, even if they're small. Become familiar with what might be in your jurisdiction. It helps address stigma and other barriers. They may not go, so it's really important to say this is just part of care and they have a right to have this also dealt with. And so really develop your own network if you can. Any style with your own questions that can be used to check in, you know, you have your own style, how you're checking in with them. You can start with things like sleeping or other symptoms and then move to the psychological more, the emotional more. If that makes you feel more comfortable, that's fine. Ask them if they've been having specific concern, how their mood's been lately. Just say cancer brings a lot of stress. How are you finding your level is? How are you managing or dealing with that? And then when you go deeper into your discussions and explorations, you can ask more about coping. Like cancer brings a lot of challenges and thoughts. Are you finding that you're thinking about anything in particular? Is there anything you're wondering about that you find that you're thinking about a lot over and over again? Is there anything that seems to cause you a particular concern or even at times frightening? This can be a common reaction. Again, you want to do anything that elicits them to open up. Now, what we try to do and the types of services that this is based on literature and just the whole structure of psychosocial support, and you're again part of it. Cognitive behavioral therapy, helping people identify maybe distorted or really inflated thoughts, maybe catastrophe type of thinking. That can be dealt with CBT programs, a lot of psychosocial services, even if they're not cancer services. If you don't have a psychosocial oncology program or psychosocial personnel around you, it could be somebody in the community. It can be another mental health professional like social worker, psychologist, psychiatrist, nurse. Um, and they're often trained in these techniques. And even if they're not working in psycho-oncology, that's fine. They know how to deal with distress. Exercise, wellness has been doing a lot too with strength training, physical exercise, walking. We know from the literature, there are randomized trials showing over and over again that exercise among clinical cancer populations is very helpful to coping, very helpful for quality of life, how they feel about their body and strength and self and their health. Very direct way of helping people with coping. The coaching type of things you do, self-management, there are online programs or websites that can be helpful. Like the Return to Work website can be very helpful. Stress reduction training, wellness, or any community program, mindfulness-based stress reduction. Those programs are often available online now or in community. They don't have to be just for cancer patients to make a difference. That kind of training is very helpful for coping, and you can guide them in those directions. Many randomized trials have been done. Support groups, and on cancer populations, by the way. Support group models. I'm a big fan. I did a lot of research on support groups. I really believe in them because when I have people in the room with shared concerns, even though there's individual personal experiences, it's excellent. They share resources. They normalize the experience. It's a place that can feel safe and they can open up and talk about things that they feel is really difficult to talk outside in the rest of the world because people don't either ask about it or feel they have to be positive all the time, or they may not feel that their peers, like say you're a woman with ovarian cancer at 40, other women at 40 who your friends may not at all be able to relate in quite the way you need them to relate. So groups can be great. So you could see what's around in your community. Wellness is great. A lot of communities do have wellness, wellspring programs. Couple counseling. I was involved in a randomized trial of couple counseling. As I said, sometimes the spouse has more distress than the person because the person with cancer is getting a lot of the attention on them, and the models of acute care focus on the treatments. We're not always checking on the spouse. And our couple counseling program was very helpful. You can go home, the spouse is there. Sometimes they have a feeling where they're wanting their person to be kind of back to normal, and that's not necessarily happening, and they may have trouble understanding that. Then you have all the body image and the sexual functioning impacts. And even though medical teams, we feel often very good about our work, and surgeons have often said this, they can do breast reconstruction, for example, but we know that hormonal treatments and men going through prostate cancer, I mean, a lot of these areas are fraught with a lot of stressors that are often dealt with alone and not brought out in the open as much. It's gotten better, but again, the spouse may have feelings that they have to go through as well and work through, like loss, feelings of stigma, shame, even disgust. Like they may have to really integrate, just like a person has to integrate changes to their body image into their sense of self if they've had surgery or changes in a sexual organ or just changes in their body in general. The couple, the spouse or partner often also has to integrate those changes. They may also feel afraid to touch or know how to have sexual experiences with a partner because they may not want to harm them or hurt them or cause any pain. They also have to expose themselves to a changed body, so that all takes time. So family therapy, couple therapy, sometimes you're dealing with children. How do I tell them about the diagnosis? I mean, I've seen all the ranges of activities. I mean, I've met patients that tried not to even tell a child that they had cancer, and they managed it fairly well, except we know from research that when you don't tell children, and again, this can be done in age appropriate ways, they know something's going on. It's amazing what children, and in fact, sometimes they magnify in their own minds that something's going on and they don't know what, and it can be bigger than it needs to be. So children have a way of figuring things out. But so sometimes there needs to be assistance with that, with a social worker that's experienced in family work to help with communication or other types of challenges, with coping with children too, because they're also going through this. Medication is required at times, and we know it's helpful. So I've certainly had lots of patients in psychotherapy that also have psychotropic medication to help them with a beyond moderate depression or a lighter depression. So they need help, and it's very beneficial. Exercise, I mentioned, nutrition is another way. These are both areas that give a patient a sense of control, something they can actually do. Doesn't have to be extreme. It's probably better not to be too extreme because, they're also recovering and so forth. But just health behaviors can be very helpful. And as I said, there are decision aids out there online. There are books in your cancer centers that you can point them towards. Websites can be helpful. I have a list of some at the end of the slides. Going back to work is a very interesting area. I was involved in a study on the development of the return to work website, and I put it on here. Oh, Cancer and Work. They have tools, they have evaluations. You can, I think, get a professional through there, but that is harder than people think. They often expect to go back similar. Some go back too soon, some don't know when to go back. So it's having guidance around that. And sometimes employers and companies are very supportive to people returning, and that's great because they need to go back often in a staged, phased way. But sometimes they're not as open to that. And so there can be challenges. And sometimes people are just reevaluating, do I want to go back to the work I was doing, or it's not a priority, or do I even want to work? And then that raises other types of challenges for them or their partners or families who expect them to just go back to who they were. So again, information. I want to tell you that information giving, which is part of what you do, giving stress management suggestions, information like CRAN provides, and other websites like the Colorectal Cancer Canada and Canadian Cancer Society. These are very important. Just knowing what to expect can be very helpful as well. This is just a man saying, I don't feel I need a support group. I've had cancer, but I have a strong desire to help. And really, the altruistic aspect is very helpful to coping, probably partly why you do what you do, but it's also very helpful to your own coping. And so some of your clients and patients might want to give back too and participate in a program like Wellspring or CRAN or other programs. This is kind of where you want to get people to, though. We all want to help our patients kind of get there. This often comes along in its own because of going through something like a cancer and its treatments or the losses associated with cancer or loss of a person. And it's a great way. It's a great way to think about life because it means people won't delay things. It means sometimes this really helps people set priorities that they maybe didn't set or do something they were delaying. And it really can add meaning and improve relationships as well, and friendships and so forth. This is some examples of some resources. I didn't check the links as much this time, but you can find them by Googling. CRAN does a lot and they keep doing more and more. And there's some other resources here. I really like the Cancer and Work website's been good, but they all have psychosocial types of information or tools. I'm a big fan of Wellspring. I do programs sometimes there. A lot of their programs now are virtually, but there's Gilda's clubs or depending on where you live. Larger cities, of course, will have more, but more and more is online. Mindfulness-based stress reduction programs. And again, they don't have to be for patients with cancer. There have been randomized trials done out of Calgary, good trials with Linda Carlson and her team showing the benefits of learning mindfulness-based stress reduction among various populations of cancer. So it's just a really good set of tools. Mygrief.ca is good, lots of tools there too when people are dealing with bereavement and loss. And that includes patients or families at end of life where the loss hasn't happened yet. There's such a thing as anticipatory grief. I have lost a spouse to cancer, and I know that very well. You start grieving before the person dies. And so there are a lot of tools there. They've been around for a while. They have some excellent resources. I think that's my slides, and you have a copy. I'm going to stop sharing. And
Thank you, Dr.
hopefully that's
Esplen.
an overview, and we can take some questions.
Absolutely. So what we'll do is the coaches will go backstage with you for our question and answer period. And thank you so much for joining us today. Psychosocial oncology is such an important part of cancer care, but is often, under addressed and under supported. And we're really grateful to have your expertise guiding us through this programming. And we hope that our patient and caregiver community will reach out to their psychosocial oncology programs at the hospital, but also to the cancer coaches to help with that kind of peer support and education piece as well.
And
So,
let me just remind you, because
yeah.
this is across Canada. Some of you will, and I'm from a rural Ontario, I'm from the farm. People that live back home, they do not have easy access to psycho-oncology programs. However, most communities, rural and otherwise, they may have a social worker in town or a small clinic. You could certainly also reach out if you're having distress or higher levels or you need more help. Try to go because they know how to manage anxiety and stress and anxiety and grief and all of that. You may be the one to educate them on cancer or not, or they may know more than you think they know, but they are also there to help. There will be somebody. So go to your family doctor. You can ask for a referral or check out what's close to you in your own community and see what you can obtain, because we're not all in large cities, and I'm very aware of that. Rather than just let it be and go on, because it may not improve. And it's an area that we can provide intervention when there needs to be more professional help.
Absolutely, absolutely. And that's a great note to end this session on. So for our viewers at home, we will see you back at 2:45 with our session on sexual health. Just a reminder to go back to your browser and enter the next session through there. And for our coaches, we will meet you backstage in just a moment.